اتفضل يا دكتور كمال بعد اذن حضرتك.
بسم الله الرحمن الرحيم. Today we have a very, very special day. Actually, we have with us Professor Amr Shaker, Assistant Professor of Internal Medicine and Nephrology, Qasr Al Aini, and he's going to talk about one of the important and practical topics we have practice every day: pigment-induced acute kidney injury. I'm sure that you are going to have a very excellent lecture and very new data. The subject is, it is subject of all of pathogenetic mechanisms, a new one. We are looking forward to hear from Professor Amr, the pigment-induced acute kidney injury. برحب بكل السادة الحضور. دكتور هشام السيد موجود معنا، ومفتقدين دكتور ياسر طبعا إن شاء الله to join us very soon. دكتور ياسر، الحضور الكريم دكتور رياض سعيد from Jordan, and all of our colleagues attendees. Actually, you are more than welcome actually to enjoy with us pigment-induced acute kidney injury from Professor Amr Shaker. تفضل دكتور عمرو.
بسم الله الرحمن الرحيم. طبعا شكرا دكتور ياسر على الدعوه الكريمه، وشكرا للتكريم.
معنا الكوردينيتور النهارده دكتور عبد الرحمن المغربي طبعا.
تمام. طبعا شكرا دكتور ياسر على الدعوه الكريمه، وشكرا دكتور كمال عكاشه على التقديم الجميل. Today we speak about pigment-induced acute kidney injury. Today we speak about the pigment-induced kidney injury. In the first, you should know that pigment-caused nephropathy is a syndrome complex associated with an abrupt decline in the renal function as a result of the toxic action of pigments on the kidney. And the major endogenous pigments for these conditions are the myoglobins that released during rhabdomyolysis, hemoglobin released during intravascular hemolysis, and bile that release in the circulation during cholestasis. So as pigment nephropathy is due to the rhabdomyolysis, that's secondary to the breakdown of muscle fibers into cellular contents that release into the systemic circulation, hemoglobinuria as a result of massive intravascular hemolysis, and bile-caused nephropathy is a form of acute kidney injury manifesting in patients with severe type hyperbilirubinemia. So what's the meaning of rhabdomyolysis? The rhabdo is a rod-shaped striated muscles breakdown. So it's a breakdown of the striated muscles. It's induced pigment nephropathy in about 70% to 15% of all cases of acute kidney injury, and is characterized by necrosis of muscle cells and the release of intracellular content into the blood. And it's typically characterized by muscle pain, weakness, red to brown urine due to myoglobin and elevated muscle enzymes, including creatine kinase in the blood. What is the causes of rhabdomyolysis? There are many causes: drug toxins, direct muscle damage, inflammatory muscle disease, muscle hypoxia, metabolic disorders, genetic disorders, hyperthermia, and infection. But when they are divided into three categories for these causes, maybe traumatic or muscle compression, non-traumatic exertional, and non-traumatic non-exertion as drugs and toxins and nitrite disorders. While the clinical manifestation is a characteristic triad of muscle pain, weakness, which most prominent in the proximal muscle groups, and dark urine. And also there is additional symptoms as malaise, fever, tachycardia, nausea, vomiting, and abdominal pain. So these are symptoms and signs. The most common symptoms and signs of rhabdomyolysis is muscle weakness, vomiting, dark color urine, fatigue, and posing. What is the laboratory finding of this? The most hallmark of the laboratory findings of rhabdomyolysis is the elevation of creatine kinase and the rich brown urine of myoglobin that's observed in only half of the cases, and its absence does not exclude the diagnosis, and I will say why. About the creatine kinase, they do a rough classification of rhabdomyolysis depending on the CK level. When the normal CK level is min 40 to 20, mild rhabdomyolysis when the CK level min 1,000 to 5,000 units per liter with low risk of acute kidney injury. But with moderate rhabdomyolysis and CK level min from 5,000 to 15,000, the risk of renal injury occur. And with severe rhabdomyolysis, when the CK level more than 15,000 per unit per liter, there is increased risk of dialysis. As the release, the myoglobin release first or the CK creatine kinase? The myoglobin release first in the first 12 to 24 hours, but the CK began to rise within 2 to 12 hours following the onset of muscle injury, reach the peak within 24 to 72 hours, and then decline within 3 to 5 days. If the creatine kinase is still to be rising and still to be high, there is a risk of the compartmental syndrome. Myoglobin is a member of a group of low molecular weight proteins, and myoglobin occur when the plasma concentration of myoglobin exceed 100 milligrams per deciliter. So the relation between the muscle and kidney is very good. There is no problem between the kidney and the muscle. But when there is rhabdomyolysis and there is a muscle pain and weakness and the muscle tissue breakdown and the release of the intercellular content of myoglobin into circulation, and this myoglobin passes into the structure of the kidney, causing acute tubular necrosis or acute kidney injury, can produce the release of the dark, rich brown urine due to the myoglobinuria. What is the mechanism of this pathogenesis or the mechanism of inducing acute kidney injury in rhabdomyolysis? First, the fluid sequestration that's occurred during rhabdomyolysis, causing hypovolemia and volume depletion, causing activation of the sympathetic nervous system and raise activation and increase the antidiuretic hormone release, causing renal vasoconstriction, afferent and efferent. And also the myoglobin, which is released into the blood and was oxidized, during oxidation of the iron, will affect the proximal tubules, inducing toxic and ischemic injury. And also the myoglobin with common precipitate with the damn-horsal protein complex forming a pigment granular cast in the distal tubules, causing distal tubule obstruction. So complication of rhabdomyolysis have many complications of rhabdomyolysis: acute kidney injury, compartmental syndrome, hypovolemia, hypocalcemia in early and due to the influx of the calcium in the muscles, and hypercalcemia that occur lately when the muscles during the recovery, hyperkalemia and hyperphosphatemia due to the release of the potassium and phosphorus from the damaged cells into the circulation and disseminated intravascular coagulation. So rhabdomyolysis will induce myoglobinemia, myoglobinuria, induce intratubular cast formation, causing tubular obstruction and acute kidney injury, and also due to third spacing, fluid sequestration, causing volume depletion and proximal tubule lesion. This endotoxins that occur due to cytokine activation, renal hyperperfusion, afferent and efferent arterial vasoconstriction. This is rhabdomyolysis. They put a score for the rhabdomyolysis to put the incidence of the acute kidney injury, the McMahon risk prediction score. They put according to the scoring according to the age, the female sex, the initial creatinine, initial calcium, initial creatine kinase, initial phosphate, and the underlying cause, and also the initial serum bicarbonate. If the scoring of the McMahon less than 6, there is a low risk of acute kidney injury. But if it's more than 6, the treatment with fluoridation is emergency and the risk of acute kidney injury is high. In 2019, there's a publication paper in the American Journal of Kidney Disease showing the rhabdomyolysis associated acute kidney injury. They take a biopsy from the renal biopsy from these patients, showing the myoglobin cast nephropathy with rich glomerular cast in the distal tubules with associated acute tubular injury in figure 1, and also in myoglobin cast nephropathy with cast positive by myoglobin immunostain. And also in 2019, about the hemolysis associated hemoglobin cast nephropathy resulted from a range of hematological disorders, showing the myoglobin cast deposition in the tubules. Hemoglobinuria. Hemoglobinuria is due to the intravascular hemolysis, is a life-threatening condition characterized by increased destruction of the erythrocytes and release of free hemoglobin. And the excess hemoglobin is filtrated by the kidney, which is released into the urine, giving a red urine color. And hemoglobinuria is a condition in which the oxygen transport protein hemoglobin is found in high concentration in the urine. What is the cause of hemoglobinuria? There are many causes of hemoglobinuria: the APO-incompatible blood transfusion, glucose 6-phosphate dehydrogenase deficiency, paroxysmal nocturnal hemoglobinuria, malaria, microangiopathic hemolytic anemia, cardiopulmonary bypass circuit, poisoning, snake bites, drug reaction, and marsh hemoglobinuria. What is the pathogenesis of heme pigment nephropathy in hemolysis, which is called hemoglobinuria? When the hemoglobin is intravascular hemolysis, there is a release of the erythrocytes and destruction of the erythrocytes. This destruction of the erythrocytes releases the iron, which is binding with the haptoglobin. This binding hemoglobin and haptoglobin be taken by the liver and the spleen. When the intravascular hemolysis, and there is many hemoglobin and iron present, haptoglobin will be saturated, So the hemoglobin will pass to the kidney, causing hemoglobinuria, hemoglobin cast formation, and the heme effect that affects the proximal tubular cells. So heme pigment injury may injure the kidneys with a volume depletion, renal vasoconstriction, direct heme protein-mediated cytotoxicity, and intraluminal cast formation. So volume depletion stimulates the sympathetic nervous system, stimulates the renin-angiotensin-aldosterone system, causing renal vasoconstriction, afferent, and opposing acute kidney injury. And also the intratubular cast formation of the interaction of the heme protein with the damn-horseful protein, causing intratubular cast formation. So hemolysis and rhabdomyolysis, both of them have the same pathogenesis of the mechanism for affecting the kidney injury, mainly due to renal vasoconstriction, tubular obstruction, and oxidative stress. And 2020, they found there is a rule of the inflammation that occurring during hemolysis and rhabdomyolysis that affects the kidney by inflammation that lead to release leukocyte, causing leukocyte infiltration, cytokine modulation, decreased neutrophil apoptosis, and increased adhesion molecules, and there is a stimulation of the leukocyte-like receptor binding protein 3 activation, inflammasome. And this is the instance, there is inflammation also of the heme, the free hemes that affect the kidney. The cytotoxic effect of the large amount of heme results from its lipophilic, oxidant, pro-inflammatory, and apoptotic effect. The kidney show marked increase in the expression of the monocyte chemoattractant protein 1 and transforming growth factor B isoform. This persistent or intermittent upregulation of these cytokines leading to a tubulointerstitial disease. How we can diagnose? First, urine analysis. Red to brown urine. The excretion of red to brown urine is observed in clinical setting. Hemoglobinuria and microbinuria, use of certain medication, and consumption of few dyes, ingestion of fluids, and acute intermittent porphyria. The standard urinary dipstick test positive in the presence of heme from myoglobin or hemoglobin or due to red cells. So dipstick positive microhematuria in the absence of any visible red cells by microscopy may signal the presence of either hemoglobinuria or myoglobinuria. And heme pigment may combine with the damn-horseful protein to give rise to a pigmented granular cast on urine microscopy. So is this in the left side? This is the urine before centrifugation. This is the RBCs and the hemoglobin. Okay. And after centrifugation, the RBCs will be disseminated down, and the hemoglobin, there is either hemoglobinuria or hemoglobinuria is still red. To differentiate between hemoglobinuria versus myoglobinuria, hemoglobin in plasma clear is low, so plasma remain red, but in myoglobin in plasma clear rapidly. So to differentiate it between with a red-brown urine color patient, bring the urine. If it's a sedimented urine, so it's a hematuria. Supernatant urine will do a dipstick. If negative, to be porphyria or due to drugs or ingestion of diet. Positive to be myoglobin or hemoglobin. See the plasma color. If it's clear, so it's hemoglobinuria. If it's red, it's hemoglobinuria. Hemolysis is also confirmed by the increased reticulocytic count and spherocytic red cells on the peripheral smear, increased reticulocytic percentage, reduced or absent level of serum haptoglobin, and maybe positive COMS test, increased serum LDH. In 2019, in 2020, there is a paper of hemoglobin cast nephropathy. They take a biopsy from patients with intravascular hemolysis, showing the hemoglobin cast in presence in the tubules. And also acute renal failure is associated with paroxysmal nocturnal hemoglobinuria, leading to intratubular hemosiderin accumulation and CD163 expression. This was a reported cases about patients with acute renal failure associated with paroxysmal nocturnal hemoglobinuria. And they take a biopsy from these patients. They found that the pigment deposit in the tubular epithelial cells, and also the pursuing blue iron stain confirms the pigmentation hemosiderin deposit. Malaria with acute renal failures, there are many papers about this. In 2000, Dr. Rashad Barsoum did a paper about the malaria acute renal failure. And also in 2002, there's acute renal failure in falciparum malaria and acute renal failure in patients with severe falciparum malaria. They found that the intravascular hemolysis and the acute inflammatory action and the immune complex disease that's occurring during malaria may causing acute kidney injury. The cardiopulmonary bypass associated with acute kidney injury, so we found that the renal ischemia perfusion and the free iron and the heme released during the operations lead to stimulation of inflammatory response and hemodynamic effect factors with this liable free iron causing acute kidney injury. And in 2019, hemolysis associated hemoglobin cast nephropathy resulting from a range of clinical pathological disorders. They found this hemolysis associated with hemoglobin gas nephropathy through a retrospective analysis of 27 cases. The mean age of the patient was 47 years, and the female to male ratio was 1.3 to 1. All patients present with acute kidney injury with mean serum creatinine 8 milligram per deciliter, and all the biopsy of this patient showing acute tubular injury and pigment cast characterized by positive hemoglobin immunohistochemistry. And after a mean follow-up, 9 months, the mean serum creatinine was 1.3, with 78% of all patients returning to normal kidney function. In 2018, the paper about the clinical profile and outcome of pigment-induced nephropathy, about 46 patients with pigment-induced nephropathy, she's showing that the pigment nephropathy due to rhabdomyolysis and hemolysis is an important cause of renal failure requiring hemodialysis, and the prognosis was relatively good and depend on the etiology. However, long-term study and follow-up needed to assess the true instance of CKD due to pigment nephropathy. So what's the prevention and the treatment of the heme pigment-induced kidney injury? The general goals for preventive therapy is to treat the underlying rhabdomyolysis or hemolysis, correction of the volume depletion if present, and prevention of intratubular cast. But how can do this? The first, volume administration. Early and aggressive fluid resuscitation maintains renal perfusion and minimizing the ischemic injuries that occur and increasing the urine flow rate, which limits the intratubular cast formation. And the initial fluid resuscitation with isotonic saline at rate 1 to 2 liters per hour, and fluid requirement be less in patients with hemolysis, as the volume depletion in hemolysis less than rhabdomyolysis. And these patients who have a heme-associated acute kidney injury in hemolysis, we suggest isotonic saline at the initial rate 100 to 200 ml per hour. When to start? When early to start, as myoglobin, when myoglobin there is a myoglobinuria, there is a nephrotoxicity from the myoglobin. As early as possible, we should start IV fluids. If the patient is volume overloaded due to present with pulmonary congestion and elevated central hemodynamic monitoring, but the peripheral edema may be present even in the absence of volume overload due to third-phase sequestration, so we don't depend on the peripheral edema. So if a diuresis is established, fluid are come to increase the follow-up the urine output to be 200 to 300 ml per hour. But is there approved for bicarbonate? If bicarbonate in patient with hemolysis or rhabdomyolysis or no? They found that alkalinization of urine to be more than 6.5 may diminish the renal toxicity of the heme. Urine alkalinization will prevent the heme protein precipitation with them-wholesome protein, and so it will decrease the intratubular pigment cast formation. And alkalinization may decrease the release of free iron from the myoglobin and the formation of iron isoprostanes, which may enhance renal vasoconstriction and decrease the risk of also of the tubular precipitation of the uric acid. But there is no clear clinical evidence that alkaline diuresis is more effective than saline diuresis in preventing acute kidney injury. And also, there is also potential risk to alkalinization of the plasma, such as it will promote calcium phosphate deposition, worsening the manifestation of hypocalcemia. And also bicarbonate may be given in the following condition. If there is a severe hypocalcemia that's not present with a symptom, arterial pH less than 7.5 and serum bicarbonate is less than 30 milliequivalent per liter. Okay, there is a lure for loop diuretics and mannitol. The use of diuretics, mannitol or furosemide to increase the diuresis has not been tested in a clinical study and is not generally recommended. However, mannitol is protected through its diuretic effect and subsequent reduction of the intratubular heme pigment deposition. And also mannitol also acts as a free radical scavenger and renal vasodilatation and reduce the blood viscosity. But if you use a high dose of mannitol, more than 200 grams per day, or accumulated dose more than 800 milligrams, have been linked to osmotic nephrosis caused by renal vasoconstriction and tubular toxicity. Loop diuretics have no impact on the outcome in acute kidney injury in the context of rhabdomyolysis. And loop diuretics may worsen the already existing trend for hypocalcemia, so it may induce calciuria and may increase the risk of cast formation.
I couldn't find the contact name to construct.
And so, when the patient has rhabdomyolysis, we assess the volume of the patient in hypovolemia, euvolemia, or hypervolemia. If the patient is hypervolemia, we don't give fluid, and if the patient is severely congested, we may consider genital diuresis or dialysis. And if the patient is hypovolemia, we give IV fluid. If euvolemia, will follow the urine output and continue fluid infusion. If the patient becomes anoric or oliguric and there is poor urine output, we should give start the risk of dialysis. Treatment of metabolic abnormality, calcium supplementation or hypocalcemia should be avoided unless there is a significant signs and symptoms of hypocalcemia, as to avoid there is the hypercalcemia that will occur during recovery to the release of the calcium from the muscles again. Hyperkalemia should be aggressively treated, and dialysis may be required to treat severe hyperkalemia. Hyperuricemia, allopurinol should be given orally at 300 milligram if uric acid level more than 8 milligram per deciliter, or if there is a 25% increase from the baseline. The third type of the pigment nephropathy is a bile cast nephropathy, and when the kidney turn yellow in 2020, this paper in the renal plasma therapy, they found that the bile cast nephropathy is a form of acute kidney injury manifesting in patients with severe direct hyperbilirubinemia, and is also known as bulimic nephropathy, bile acid nephropathy, biliary nephrosis, and jaundice-related nephropathy. The bile salts have low solubility in water, and normally when filtrated by the glomeruli, they are transported by the proximal tubules back into circulation. In hyperbilirubinemia, these transporters will be saturated, causing the tubules to be overflowed with bilirubin, a key factor to enhance cast formation and subsequently tubular obstruction. And it has been reported that in some cases, the renal clearance of bilirubin increased from below 5% to almost 90%. So what is the pathogenesis of this? When there is advanced liver disease or hyperbilirubinemia, this uncoupling of the oxidative phosphorylation in the mitochondria causing depletion of the adenosine triphosphate that increase the mitochondrial permeability and increase the plasma membrane damage. Causes acute kidney injury due to interstitial inflammation and fibrosis affecting the proximal tubule, leading to cast formation and tubular obstruction. The sodium bile co-transport impairment that reducing the production of superoxide and sodium reabsorption in the thick ascending loop of renal, causing stimulation of the angiotensin II that affects that and impairs the mobility and tonicity of the afferent and efferent arterioles, decreasing the arterial hypertension, and the loss of tubular architecture and due to hypertrophy and hyperplasia causing necrosis. So bile acid and bile cause nephropathy may be direct effect from the bile acid and the bilirubin, causing acute tubular injury, tubular interstitial inflammation, intratubular obstruction, or secondary to the hemodynamics that occurred with acute decompensated cirrhosis or to the pre-renal acute kidney injury, ischemia, and nephrotoxins, causing acute tubular necrosis or acute interstitial nephritis. In 2015, they did full bile cast nephropathy paper showing this presence of urine microscopy showing the presence of bile cast, and we'll take a biopsy from this patient showing the bile cast in the renal tubules and showing the bile stains is a greenish presentation of the bile cast in the tubules. In these studies showing the clinical and pathological characteristics of the biopsy in patient with bile cast nephropathy, reporting from since 2000, most of the patients they have taken biopsies, there was acute tubular necrosis or there is a bile cast nephropathy that causing the acute kidney injury. To summarize this, so we have a bile cast nephropathy present with acute kidney injury, jaundice, hyperbilirubinemia, urine sodium low, hyperuricemia, and hypokalemia. There is mechanism by tubular epithelial injury, basement membrane effect causing tubular leakage and obstruction, acidic urine precipitate bile cast, and low perfusion state. When showing the urine analysis, will show a urinary bilirubin cast, and in biopsy, acute tubular necrosis, and we can show urinary bilirubin crystals and bile casts by Hill stain. So the treatment and the outcome. Several case studies reported reversal of acute kidney injury with the reduction of the bile salts and bilirubin level at different recovery rate, focusing on decreasing the bilirubin level and reversing the cause of liver injury. In 2020, there is about the treatment of bile cast nephropathy. It was a comprehensive review showing the extracorporeal therapy for bile cast nephropathy divided into two major groups, biological and non-biological. Biological device using liver cells, and non-biological device using artificial membrane as an absorbent for detoxification, including plasmapheresis and albumin dialysis. The plasmapheresis can be utilized to remove the excess toxin and bilirubin in persistent cholestasis to improve the symptoms and the outcome. And not only it replenishes the albumin coagulation factors and hepatic regenerative stimulating substance. And the albumin dialysis is based on the removal of the unwanted albumin-bound and water-soluble substance such as bilirubin, bile acids, and other hepatotoxins, which are mostly albumin-bound. There are two forms: the nuclear absorbent recirculating system and the single bus albumin dialysis. This is a figure showing the molecular adsorbent recirculating system and the single pass albumin dialysis. When we take the molecular absorbent recirculating system, we have a blood circuit, albumin circuit, and dialysate circuit. The blood taken from the patient passing through the albumin, the MARS, the molecular adsorbent recirculating membrane, where the albumin came, taking the toxin substance, and the albumin go to the dialysate membrane with the bicarbonate circuit, and return again to the activated charcoal membrane and the anion exchange result. And this figure showing is when the blood with albumin with toxin molecules came, taking these toxin molecules in the albumin, with taking by the new albumin through the membrane, the molecular adsorbent membrane, then passing again to the bicarbonate and the dialysate flow, in which the albumin become clear, passing to the charcoal membranes and the anion exchange result. What's the molecular absorbent recirculating system? It can be dialyzed both water-soluble substance as ammonia, urea, creatinine, and also albumin-bounded substance, bilirubin, bile acids, tryptophan, and fatty acids, copper, and benzodiazepines. The artificial liver support system showing is a new over last decade. It was a paper in 2018 by the Annals of Intensive Care, showing the studies that use the molecular adsorbent recirculating system about the results, and it is improvement in the patient, but it was improves patient who will do a transplantation for this patient. And also in another patients about this molecular adsorbent recirculating system in patient with type 1 hepatorenal syndrome and severe cholestatic chlorides and post-hepatectomy liver failure. There was no improvement in the renal function and no improvement in hemodynamics. The medical therapy using steroid, ursodeoxycholic acid, cholestyramine, or lactulose have a little to no benefit in bile cast nephropathy, and there is no systemic guidelines until now for the diagnosis, treating, and managing in patients presenting with bulimic nephropathy or bile cast nephropathy. So we'll take a home message that pigment cast nephropathy is a syndrome complex associated with a rapid decline in the renal function as a result of toxic action of pigment on the kidney. Timely diagnosis and treatment lead to good outcome, as the prognosis was relatively good and depend on the etiology. However, long-term studies and follow-up are needed to assess the true instance of CKD due to pigment nephropathy. Thank you.
Thank you very much, Dr. Amr, for this elegant presentation and very illustrative, actually, for one of the mysterious topics that we have in clinical practice. I mean, yeah, we can say it is just one of the very common clinical scenarios that you have in clinical practice. So you explained everything very well. Thank you very much, actually, for being with us and sharing us your experience in this issue. And I think Dr. Yasser, welcome. Dr. Yasser Abdelhamid is with us now. Dr. Yasser, I can see you.
Yes, Professor Kamal.
أهلا دكتور ياسر, أهلا بيك.
Thank you. Thank you, Professor Amr. Thank you, Professor Kamal. I miss you too. Miss you all. And excuse me for this. You know, really a great lecture and illustrative lecture.
Yeah, really.
Illustrated all aspects of pigment-induced AKI. And I will stay in background, enjoying the discussion that we will lead, Professor Kamal, of course.
Thank you very much, Dr. Yasser. We're missing you.
Thank you.
You know, you are one of the pillars of this continuous medical education actually series. Yeah, we ask Allah just to keep up, inshallah, and enjoying. And
thank you, Professor Amr.
Dr. Amr mentioned that we are just missing Professor Rashad Barsum. Actually, you mentioned one of his paper for myoglobinuria, and we are really missing him so much. And may Allah forgive him and give him the mercy. طبعا النهارده يعني اعتقد ده اول يوم يمكن بعد رحيل استاذنا الدكتور رشاد نبدا الكونتينوس ميديكال اديوكيشن سيريز. وكان طبعا محاضره شيقه و very attractive from Dr. Amr Shaker, and we may open the discussion for our audience. And just to I think I don't have any in the chat. Do you have something on the chat? we may have thanks. Oh, that's everybody's thanking you, Dr. Amr. Yeah. So I may start by myself actually, and just to say thank you, Dr. Amr, actually for the elegant presentation, and you explained a lot of pathogenetic mechanism. As I expected, actually, is that you are going to talk in a non-traditional way, and you highlighted elegantly the role of inflammation and the inflammasomes and the pathogenesis of rhabdomyolysis and pigment-induced acute kidney injury in general. I think I have one question. I think everybody just has the same feeling that does the steroid have a role in management and rhabdomyolysis, even as sometimes?
Yes, there is some papers says about the rules of steroid in rhabdomyolysis, but after that, all the papers and the studies shows there is no improvement, and there is no additional benefit from this.
As you mentioned, it was one of very few sporadic cases actually.
Yes,
but
yes.
I think for a reason or the other, we may use intravenous steroid, especially for cases which may be assumed to have inflammation as predisposing factor. I think this may be the rationale beyond use of steroid in such patients.
Yes, because the pathogenesis of the pigment nephropathy, the last paper was 2020 about the inflammasome, about the stimulation of the nucleotide like polypeptide receptor binding protein 3. I say in the pathogenesis, the rules is the inflammation also is not acute intratubular precipitation, and is due to pigment nephropathy of direct injury of the proximal tubules and ischemia or volume depletion. But there is a rule for the inflammasomes, the inflammation. So maybe after that there be a rule of the steroids as an inflammation disease. Maybe rhabdomyolysis, the intravascular hemolysis, the acute kidney injury, maybe have a rule for the inflammation. And after that, maybe in the management, that steroids will be the first line of treatment after that.
Yeah, especially in those patients who's in LLBR3 are one of the markers for diagnosis of such a patient. Yeah. And I think we have lots of our friends joined us. We have, I think, Dr. Tariq Tantawi joined us, Dr. Ahmed Faid. All right. Dr. Nadra, Dr. Dina Munir, Dr. Al-Alim, Dr. Tariq left, Dr. Tariq Tantawi. Professor Riyad Saeed is still with us.
نعم يا باشا نعم.
We need your input.
يلا يخليك مساء الخير. I have really two comments about nowadays we are seeing more and more non-traumatic, I'd like to stress this, non-traumatic rhabdomyolysis than traumatic rhabdomyolysis. That's really one of the most important things. And we have that electrolyte imbalance mostly with the syndrome of hypophosphatemia and hypokalemia. That's usually we have to be bear in mind. So non-traumatic, and the mainstay really of management is early intervention and hydration. I hear my colleague mentioning about use of bicarbonate. That's maybe not really with rhabdomyolysis, but with hemoglobinuria. Usually alkalinization of the urine, it may be of help simply because the hemoglobin itself is not toxic to the kidneys, but really when it's being acidified into an acid hematine in the renal tubules, it will cause the damage. So alkalinization of the urine with hemoglobinuria, it seems to be really still a valid option in conjunction with forced diuresis. That's really the comment that I have about this. Concerning bile hemoglobinuria, my question really, how frequently you have to do a kidney biopsy in a patient with INR usually is quite high and all that. So really the diagnosis, it seems to be a little bit shaky. And the kidney biopsy is usually being done. Is it done during really the high bilirubin, high PT, PTT, INR or not? And thank you.
Yeah, it's very tricky. Yeah. But,
About
what-
the bicarbonate, 4 years later, I see the same picture before. I was told about the bicarbonate is a very important for the treatment of hemoglobinuria and intravascular hemolysis at acute kidney injury. But now there is no all the studies, there is no rule for the alkalinization of urine. And there is alkalinization of urine if given there is an indication of the alkalinization of urine. As there is a potential risk factor, but also there is an indication. If we have no hypocalcemia, if we have no hypermetabolic, if we don't have metabolic acidosis, so we can alkalinization. We can alkalinization, but there is a potential risk for this. But no, if it's not a good true, you should give it, and also it's a false to stop it. But there is a potential risk for the complications that may occur with the IV carbonate.
Professor Hisham Said raised his hand. Yeah, please, Dr. Hisham.
Thank you very much, Professor Amr, for very informative, illuminating talk, and thank you again for Professor Kamal Okasha for the best driving the talk. And got well soon, Professor Yasser Abdel Hamid. I missed you also last week because when I am giving my talk on the ESA. I have a comment and a question. My comment here, I was asked today morning on a case of rhabdomyolysis in a young female in our university hospital toxicology unit. The CBK was 230,000 and the patient had acute kidney injury. What is the best dialysis if I am going to do a dialysis for these patients? Not all dialysis are equal in the prognosis, although there is no too much of the randomized control trial differentiation between dialysis techniques. But my opinion here, the myoglobin, if we need to remove myoglobin, it's a very difficult molecule to be removed during dialysis. Number one, because it's a globular protein, the molecular weight is 17.8 thousand Dalton, but it's a very globular and it is unfolded. So it cannot be easily squeezed between the dialysis membrane as other toxin in the same molecular weight, for example, the cytokine, which is in the same range, interleukin 1, could be removed easier than the myoglobin. The myoglobin shape decrease the removal. But if I am going to do dialysis, so acute kidney injury, I will be sure that the dialysis membrane porosity can remove the myoglobin more efficiently. On the market, we have only 2 dialyzers available for removing that myoglobin because the receiving coefficient is high. One is the BioPure 0.7 myoglobin, and the second one is the Rivaclear 0.68 from Pakistan and from Omid. So I decided to give the patient the best chance of removal of myoglobin. The second, we have to do more prolonged because the production is very high. So short intermittent dialysis will not be of value if we need to remove much more of the myoglobin till the recovery by hydration and other treatment described perfectly from your talk. So dialysis prescription in those patients needs more attention, not a routine dialysis, low flux or high flux dialysis, but more toward removal of the, unless that it's a 3.5 nanometer in diameter, the myoglobin, it is nearly half of the albumin, but the albumin could be removed easier because it's unfolded and squeezed between the dialysis membrane.
Yeah. Very important.
So this is one of the concepts when you are doing dialysis prescription in patients with myoglobinuria and the crash syndrome and for any of the causes of rhabdomyolysis. My question to Dr. Amr, just I wonder, what is the markers of the prognosis or the magnitude of acute kidney injury? Plus the urine output, for sure, it is one of the best. But if you think that the creatinine, serum creatinine and PUN, creatinine may be mostly high rather than the PUN. So what's your opinion? What's to consider, the PUN with the volume depletion will be high, but with serum creatinine will be high as well for the rhabdomyolysis, the ratio, and I don't think so that it's described in the literature well. So please give me your opinion.
About the prognosis of the patients with rhabdomyolysis?
Not only the prognosis, the marker of injury for the acute kidney injury. We may see that serum creatinine may rise due to increase in creatine phosphokinase, and the PON is not too much high in correlation with the serum creatinine. So what do you think that if I'm giving a message to the colleagues who are following up the rhabdomyolysis day by day on the biomarkers? Yes, I think urine output one of the best in this case.
Excuse me, Professor Hisham and Professor Amr. I think we are to go to urine output and rifle criteria, urine output and rise of serum creatinine, and in this case, meaning being a tubular element, we can. I think urine output will be affected.
I think Dr. Hisham is asking for something very unique for rhabdomyolysis in terms of acute kidney injury related rhabdomyolysis. So if you allow me just to, how about the markers of rhabdomyolysis itself, like CK, and the most important is either urine or serum myoglobin.
Yes.
So which are, I think, by far one of the most important indicators for the progression of rhabdomyolysis.
Yes, but if you agree with me that serum creatinine may be higher than expected in AKI due to rhabdomyolysis, if I am right on that?
Creatinine for sure will be much higher.
So yes, so today I asked the patient because they called me for this dialysis prescription in this young lady. The creatinine was just 1.4, but the PON is higher than expected. So my question to the residents, what is that CVP? Because if you have a high PON correlated to creatinine, the patient may be dehydrated, but it was 20. So that makes me sensing that I don't rely on creatinine, I will rely only on the urine output. Serum myoglobin is not commonly to do in practice. So I think we have to do more or less the other biomarkers of kidney injury rather than creatinine.
Yeah, we have some questions on chat for Dr. Amr. How about hypothyroidism induced rhabdomyolysis?
The hypothyroidism can be induced rhabdomyolysis.
Yeah, of course. Yeah, can be used.
Okay.
Yeah.
One of them can cause myopathy.
Yeah.
Without physical exertion or with physical exertion, because hypothyroid on stationary state may not induce, but on exertional state.
Yes.
Exertion, yes.
With exertion.
Even they're talking, most of them receiving lipid medicine. So
I want to ask about
very predisposed to have it. Yeah.
About that.
About disproportionate. That's what Dr. Hisham was talking about.
Yes.
This is one of the questions that I have on chat. Disproportionate uremia with high serum creatinine and low urea. So I think this is a typical example that we have.
Yes.
In our condition.
As we see about in the presentation, we see about the McMahon scoring for the rhabdomyolysis, and this scoring for rhabdomyolysis about the risk of acute kidney injury. They depend on the age, on the serum initial creatinine, the initial bicarbonate, the initial phosphorus, and the initial CK. The first scoring system for the rhabdomyolysis. And if the scoring is less than 6, the risk of acute kidney injury is low. And if the scoring more than 6, there is a risk of acute kidney is high. This is the first. And about the classification, the rough classification of rhabdomyolysis according to the CK, they found that the patient has rising of the CK more than 15,000 units per milli. The risk of acute kidney injury and the dialysis may be high, as is a stage 4 for rhabdomyolysis.
Yes. This another Dr. Ahmed Faid is asking urine output with a target of 15 milliliter per kg per hour. Is that what you're it is some fact would you like to deliver to us, Dr. Ahmed, or is this what the patient should be?
Dear Dr. Kamal, this is my answer for Dr. Hisham about the adequate urine output that follow up, which is a good marker in the cases of the rhabdomyolysis to be targeted with the 15 milliliter per kilogram with hour, which is is a good marker that we follow up in the ICU and in the intensive care for about the urine output, and also the scoring system that my colleague Dr. Amr say. But the urine output, as Dr. Hisham say, it is the main or the golden standard for follow up during our follow-up of the patients.
We all agree. Even Dr. Amr mentioned it actually from 200 to 300 milliliter per hour. That I remember that very much. Any more questions here? I think, but everybody is thanking you here actually, as I can see from the chat, Dr. Amr. And I think just to wrap up this elegant presentation actually, and this very important topic, the scenario, the clinical scenario, and taking, appropriate history from the patient is very important, because as you mentioned, Dr. Amr, it's multifactorial. It may be induced by trauma, as Professor Riyad Saeed mentioned, and non-trauma. And non-trauma is very much actually,
much commoner.
Yeah, medications like statin very easily. Patient with myself, I so many patients actually, bodybuilder, receiving this some sort of anabolics, basically just induce huge muscles, big muscles, and exercises, and very easily could induce rhabdomyolysis. And I think many of you also have seen such situation and such cases. So I enjoyed your talk very well, Dr. Amr. Really, it was very interesting.
Thank you.
Yeah, and as everybody does, right? we really did, Dr. Amr, and thank you very much. And still, we have some time for any questions from our attendees, actually, just to share with us very elegant night, actually, with Professor Amr Shaker.
في سؤال لو سمحت يا دكتور، في سؤال على الشات.
اتفضل يا فندم. Please, can you explain the treatment of bile cast nephropathy as regards the albumin dialysis?
Yes. About the albumin dialysis.
انت قلت حضرتك ذكرته في سياق الكلام.
الاستاد single pass albumin dialysis.
single pass albumin dialysis.
Single pass albumin dialysis. وفي recirculating dialysis. السنجل albumin dialysis عامل زي الكونتينيو venous hemodifiltration with albumin dilate, and also another filter for the dialysis. باطي حقيقه يعني انا ما شفتش ما عندناش في مصر، مش عارف يعني مش عندنا في القصر العيني.
I did that before instead for such cases, because in the literature the result is nearly like mass. We use albumin infusate in dialysate. Simply we can have a dialysate bag like peritoneal dialysis bags. We can put, or even we can induce a tank of dialysate, because we need a single pump, 2 machines, or a machine with 2 pumps. And the dialysate albumin concentration is 4%. So traditionally, one vial of albumin 100 cc, 20% will be diluted 5 times. And we move that dialysate very slowly, about 100 milli per minute. And in exchanging the bile salts or albumin bounded toxin on the blood side. This is the single pass albumin dialysate, because it is not reusable, because it's moved out to the waste. So 4% dialysate albumin. You can do it on your unit simply by giving a dialysate solution with 4% albumin, and with additional pump, you can infuse that on the dialysate side of the filter in a slow technique.
Yeah, I think it is the same mechanism like immune absorption, Dr. Hisham. Exactly, it's like immune absorption.
Yes, but here we use a hemofilter like a dialyzer porous membrane, high flux or superflux dialysis membrane, without resin or adsorbent material. But in
the
contact,
albumin will take this
yes,
take this
by
function
contact, yes,
as a coating for the filter to have
yes,
the same mechanism.
yes, yes, just to displace between the small toxins bounded to albumin on one side to the other side in 4% albumin in dialysis.
Any more questions from our colleagues, dear audience, dear professors, attendees, dear colleagues?
Thank you very much. Thank you very much, and hopefully that you have a good evening.
We had actually with Dr. Amr and all of you, Dr. Hisham and everyone. Thank you very much, Dr. Amr, for this very elegant presentation. And Dr. Yasser, just will be back soon, inshallah, to enjoy being with you again. Thank you everyone actually for attending and being with us. Dr. Hisham, Dr. Riyad Saeed, Dr. Tariq Tantawi, he just attended and left, and everyone in the chat. Thank you very much for being with us.
Thank you very much.
And we hope you enjoyed staying with us. Thank you very much again. Shukran, Dr. Amr. Shukran, Dr. Hisham. Thanks everyone. دكتور ياسر ان شاء الله تبقى معنا على طول very soon ان شاء الله.
شكرا
دكتور عبد الرحمن.
شكرا
معتصم and everyone, just the the technical issues. Thank you very much. Dr. Ahmed, thank you. See you.
شكرا دكتور.
Have a good night everyone.